Ja, we gaan starten. Okay, good morning everyone, and welcome, and thank you for being here or for connecting to us on the web. This is the second seminar or webinar in a series of 5 in which researchers of Lucas, KU Leuven, which is an interdisciplinary research center for care and consultancy, in which they talk about how they investigate implementation in different fields of health and well-being. And this is one of the ways in which we celebrate 30 years of the 30th anniversary of Lucas. Feel free to ask questions, but we'll keep them to the end, so you can ask questions either via chat on YouTube or live, of course, here. In this webinar, I would like to talk about the implementation of BelRAI and how we study that process. I'll start with explaining what the problem is and why we want to implement BelRAI, and then I'll talk some more about what exactly it is. And in the end, I'll go into the process of implementation and how we study that implementation process. So what's the problem? Why do we need something like BelRAI? Well, as you probably know, the number of people who need care and support increases. There's more people who need help either because they have mental health problems or they become older or they have disabilities, etc. And these people do not stay in one organization for the whole care trajectory they have. They move from one organization to another. They have home care for a number of years, and then maybe they go into a nursing home, and in between they may have had 1 or 2 visits to a hospital. Or somebody has a stroke or an accident, is in acute care, and then has rehab, and that rehab may be residential for a while, and then become ambulatory, etc. And maybe they also need some home care afterwards because they have disabilities. And a person may have chronic mental health problems, live at home with support from an ambulatory team and regular home care services, but now and then there is something happening or there's a crisis, and then that person needs hospitalization. So people move around. They don't stay in one place. But the problem is, this is life in health and social care, but the problem is that there are different organizations and different sectors, and they share little or no information. So when you move from one organization to the other, the information about you stays in the first organization on a computer, or maybe in a file on a desk, and in a worst-case scenario, in the head of the person who took care of you, and it doesn't move. That implies that people have to answer the same questions over and over, because in every new organization they come into, they have to repeat what they said before, and staff loses time and has to look for information that somebody else already collected. So why is that? Well, partly because there are gaps between sectors and silos. We have different types of organizations and even different government agencies responsible for people with disabilities, people with mental health problems, young people, maybe even young people with disabilities or mental health problems, older people. There are silos, and that implies also a lack of continuity of care, because if you have to start anew, there's a period in which you don't know enough about that person to properly take care of them, and then that also implies, I think, loss of quality of care, and on time spent on quality of care. So part of the solution to solve that, not the whole thing, of course, but part of it, is that all those people and all those organizations and all those sectors would start using the same system of assessment. And those are the interRAI instruments. They are 3rd-generation comprehensive assessment instruments, which implies that, well, 1st generation was assessment instruments on one topic, for example, ADL, IADL, or cognition. 2nd generation was on several topics, but within one sector, so physical, mental, and social health, but in one sector. And the 3rd generation of assessment systems works across sectors. So data can follow you through from home care to hospital, back to home, maybe to residential care, etc. And the thing about that is also that the same thing is always measured in the same way. If they want to know whether you can bathe yourself, it's always measured in the same way and all across sectors, in mental health, in elderly care, in rehab, but also in home care, in hospitals, everywhere. So the data follows the person, instead of you having to run around to find the data about that person or have to start anew. And the interRAI suite of instruments, as it is called, has instruments from birth. There's an instrument for 0 to 3-year-olds who are born with some difficulties, have developmental problems, for children with mental health problems, also for youths who get in touch with justice for one reason or another. There's instruments for people with mental health problems, instruments for people with disabilities, for older people, and even an instrument for palliative care. So if you're very unlucky, interRAI could be following you from birth to death. And it can be used in all sectors involved. And so BelRAI is actually the Belgian version of these instruments. What does that imply? They're internationally validated instruments, so we don't change too much about them. But it means we translated them into the 3 national languages, Dutch, French, and German. And we made some adaptations to the local situation, mainly about things such as the type of organizations we have here, the way care is organized in Belgium. But not to the core of it, of course. We're not going to change something in the way we, for example, measure cognition, because if we do that, we no longer have a validated instrument. So what we use here in Belgium at the moment is in home care a screener, BelRAI screener, for adults and for children, 2 different screeners. We have a very accessible system. We need a screener to see who needs the full assessment and who doesn't yet because they have less complex problems. We have the interRAI home care instrument, the interRAI community mental health instrument, and a supplement for people with addictions. We have a subjective quality of life instrument for the community mental health, which is something that is filled out by the person themselves, about how they evaluate their quality of life and the care they receive. And we are working on an instrument for rehabilitation, a BelRAI rehab. In residential care, we have the long-term care facilities instrument, which is used in nursing homes, and also an SQOL instrument that is filled out by people who live in a nursing home and who are cognitively sufficiently intact to be able to fill out a questionnaire on how they experience that care. You can find data on nursing home, people living in nursing homes in Flanders for over 6,000 people who filled out that questionnaire, and we can see where things go well and where there is room for improvement. In hospital, there is a whole suite of acute care instruments. There's a comprehensive geriatric assessment and an acute care assessment, and a mental health instrument for psychiatric hospitals. And in between, that rehab instrument can be used residential as well as ambulatory and in post-acute care. And everywhere we can use the interRAI palliative care instrument at home as well as in a hospital or someplace else. What is such an instrument? It's a list of items, the things you know. You ask or you assess whether somebody can walk, but you also assess which activities they like and whether they are socially engaged, whether they are lonely, whether they have informal caregivers, and whether those informal caregivers are still capable of taking up the care and willing to do more or feeling overwhelmed. There are questions about mental health and mood, whether they feel happy or not, etc. So a list of items that has to be filled out by someone or a number of people. But linked to that are also algorithms that calculate outcomes that help you for designing a care plan, for example. So we have results at the micro level of that person, scales and CAPs, which are clinical assessment protocols, and which give you a type of alarm. Oh, that person is not participating in activities as much as before, and mood has declined. Maybe you should look into that, because there may be a problem arising. Or that person has been in hospital and came back incontinent, but perhaps we can reverse that with the right training, and that will work. And then you have results at the meso level. If you have all that data from everybody in your organization, you can start looking at quality indicators, for example. You can look at whether many people obtain a pressure ulcer in your organization. Well, are they there? And you want that number to be 0. You will look at that. You can also look at whether the care mix is different in different parts of your organization. Typical comment in a nursing home will be that in our ward at this point in time, care is a lot heavier than in the other ward, and we need more people. Well, you can objectify that and look whether it's true or not. There are care mix indices. And then you can decide whether you will adapt your staff temporarily for taking care of that. And if you have that type of data for a whole region, or for a whole country even, then of course you have good data to build your policy upon and to evaluate your policy upon. For example, if you notice that compared to other countries, because there's many other countries using the same instruments, you have more informal caregivers who feel overwhelmed while the care of the person is about the same as in the other countries. So how heavy the care is the same, but they feel more overwhelmed. Well, that would be a point in time when government should have a plan to ameliorate that and do something about that. And you can evaluate it. You can evaluate your care plan for that individual person. You can evaluate whether your organization is doing better quality-wise. And you can evaluate whether your policy plan is working, because 6 months or a year later, you have new assessments and we'll know more about it. So you have results across settings and across time, which helps you to give better continuity of care. It is used as a multidisciplinary assessment. Most of the assessments have 300 to 400 items. It's quite long because it covers a lot of fields. But you don't have to be the only one to fill it out. Everybody can do their piece, everybody involved in care. So the physio may do a part of it, and the social worker may do part of it, and the nurse will do part, and the physician may do part. And it's all done by people who know the person, have a therapeutic relationship with that person. It's professional driven. It's filled out by professionals. You use software because if not, you will never have the outcomes. You will not be calculating all the caps and scales yourself, so you need software. And also, if you do it on paper, it's not shared with other people and you have the same problem as before. It stays on your desk and it's not available for the next one in the care trajectory. There is software offered by government, free, and there is software, commercial software, that is more user-friendly because it's a tablet and you don't have to be connected to the internet to fill it out. But every software that is on the Belgian market has to be approved by government to make sure that the quality of the assessment and they use the right version and the right translations and all the data go to the same server so that when somebody else uses other software, they can use your data as well. It's been through a whole process with eHealth for privacy and safety, and you get immediate feedback of results and all data go to one place. If you hear that, I suppose you would think that implementing a thing like that would be a piece of cake. It would be very easy because everybody will see the benefits, and it should be very easy to implement it because it will ameliorate a lot of things and it will solve a lot of problems. Well, no. There's a whole history behind BelRAI. We started in 2005. It's 2019 now. Implementation is ongoing and is happening, but it's a slow and tedious process. You can see there's been a whole, it's not as if there were gaps. There's been a whole list of projects. We've done a lot, we've worked a lot, but it still isn't fully implemented in the whole of Belgium. Even though there are decrees and official government plans, it's an action point on the eHealth roadmap. It should have been, some of the instruments should have been implemented by last year or the year before, according to that plan. It's mentioned in a number of decrees. And it is happening, but it's not like the straight line you see on the one side, but rather like the other, less clear line. Things go well, and then you have a setback, and things go well again, and there's another setback, and there's always something you did not think about. And what we see is that when we do research, so there's always been, in the implementation, there's always been researchers involved from different universities and different parts of the country. But the focus of research is often solely or mainly on the result of the research, the product, the assessment and the software in a good form, and the training is perfect, and it's been validated, etc. We know for sure that the same thing is always measured validly in the same way. But there's less attention for implementation and valorization. There is a process in the usability of products. If we cannot convince the users that it actually is better than what they did before, they will not use it. Or they'll use it, but only because they have to, and so not in a very good way. And there is a complex context around it that is social, but also environmental and policy related. And I'll try and go into that some more. So what makes an intervention complex? Well, because there are interacting components, for example. We do not work in an RCT, in a randomized controlled trial, where you can put all other circumstances in a kind of laboratory where you can take care of only one thing you change and nothing else changes at the same time. Well, in health and well-being and health and care, that's not the case. It's never just one thing happening. There are many policy changes, there are many innovations. Sometimes there's innovation fatigue in people who feel like they have to do things in a different way all the time, and maybe they even feel like they're not being valued because they always have to change things as if they didn't do things well before. And it's very important then to talk with them, to listen to them, to hear all their comments. And the very first BelRAI report in the beginning of 2007, was like this, and it was full of complaints of all the things that were not good. And that's a bit of a setback at first, but then that report helped us a lot to, we constructed new training afterwards, we constructed new software afterwards, we ameliorated the translations. We had started with the French translations for the French-speaking part of the country and the Dutch translations from the Netherlands for the Dutch-speaking part of the country, and we found that there are nuances in language that didn't take account of, and we had to make Flemish versions and Walloon versions. And so there's a lot of things that interact, and it's also another way of working. It requires other behaviors. People who did not collaborate before need to collaborate now, and they need to share data, which is also kind of scary to some people, because others will see whether they did something well or not so well, and how they evaluated somebody, and maybe they have another ID, etc. There was a fear for automatic care planning, that there would be some kind of robotic thing that would come out and that would say, this is the BelRAI assessment for this person, so this should be the care plan, which is also not the case. People with the same assessment can have very different goals in life, very different backgrounds, and therefore preferences for a completely different care plan. Fear for use for financing, or wanting to use it for financing. Some sectors thought they can gain, and other things they can lose. And so there's also different types of outcomes that happen when you start using BelRAI, not just better quality of care, which of course is the aim, but also different types of interaction, different types of collaboration. In one of the projects, we had regions work together in home care, residential care, and hospitals. And we found that they spent, the year they had for the project, they spent 9 to 10 months of that period of time in finding new ways of collaborating and knowing who is also taking care of that same person in a network, because they didn't know before, and there were only 2 months left to use the instrument. So there's different types that interact. And you need a degree of flexibility and of tailoring and of reworking things. And it differs, of course, at the very beginning and then later, and now we are at a phase in which we, for at least some of the instruments, are ready for full implementation. So if you want to, there's a lot of things going on. If you want to have a more structured view on what is going on and what you should be taking account of and how you could be studying this, then you need some kind of theoretical and practical framework that helps you through that. And for BelRAI, we use the MRC framework, which is the Medical Research Council framework. At the end of the presentation, there's a reference where you can find some literature on that. Because it's just an instrument. BelRAI is no more than an assessment instrument, but the implementation implies a change in culture. It forces to collaborate. It forces you to share information you have never shared before, and there are many, many stakeholders involved. And that makes it a complex intervention in which there are always factors that you cannot control, that you cannot say, we'll put that on hold and we'll do the rest. There's never an opportunity to keep something on hold. It provides structure to study that and to see under what conditions BelRAI can successfully be implemented in different sectors. And it's an important framework that has mainly been used in medical research so far, but that also is a feasible framework for more social and sociological research even. It helps to prepare next phases because you can structure what happened and see where you went wrong or what you did not think about. And helps you to structure the next one. It helps to understand why things are working or not working, because not everything is predictable. I forgot a not there. It's not that everything is predictable, it's exactly the opposite. It's everything is not predictable. and it helps you to structure. And the main framework, the key elements are these. There's a development phase, there's a feasibility or piloting phase, there's an evaluation phase, and an implementation phase. But it's not as if there's a direct line from one to the other. You often have to go back to a previous phase. You may be in the implementation phase and have to go back to development or to feasibility, and you always have to re-evaluate whether what is happening is what you want to be happening. So let me explain a little bit more about that per phase. For example, if you look at development, you will have to look at what evidence is there that BelRAI will have positive outcomes on quality of care, on quality of work, etc. What do we want to achieve with BelRAI? Do we want a better financing system, or do we first and for all want better quality of care, and then if that all works, then we maybe can look at financing, and how do we want to achieve that? And for example, there is a huge body of research since it's internationally validated instruments. interRAI is a non-profit organization that brings together over 120 researchers from over 35 countries. Instruments are being used in all continents except for Antarctica, for obvious reasons, I guess. So you also know that it's intercultural. You can use it in very different cultures. There's huge use in New Zealand, and there's huge use in Belgium and in Finland, and in Canada and in the United States, but there's also use in Singapore, and they're contemplating full implementation right now. There's use in Hong Kong, there's use in South Korea, there's use in South Africa, there's use in Brazil, etc. And all of these countries have been through the same type of implementation process. So you can learn from what they have done, but you cannot copy it. So if you look at websites such as Google Scholar or Web of Science, you'll find a lot of literature of people who have studied what had happened before, and you can prove to users, you can show to users that indeed in those other countries there were, for example, less unnecessary hospitalizations, which is good for the quality of life of the person. Nobody wants to be hospitalized. It's also good for society because hospitalizations cost a lot of money, etc. Another thing you have to think about during the development phase is who do we have to involve? It's not something you can do from an ivory tower in an office here someplace in Leuven, and you draw all the necessary conditions and you tell them, just do this and it will be okay. That's not how it works. You have to involve everybody. And it's a multi-level context in which I'm a bit inspired by the evidence integration triangle by Glasgow and others. You have to involve clients, families, and patients, because if they feel like, I don't want to share my data, who is going to be able to see when everything is on a server? Is my neighbor who works in a care organization going to be able to look at my file and see that maybe my mood was less well last year and that maybe I'm incontinent? I don't want that, and of course you don't. So you have to take account of... Also, you have to ask them what they feel like sharing and what they don't feel like sharing, and also what they want their caregivers to know about them and to ask them, because sometimes they also say that they want to tell more, but nobody's listening. At the organizational level, you have to include the organizations, because using something new will cost them and their staff time and probably money, and they have to be motivated and see the benefits, or they won't be doing it. You have to have policy and governments involved, and not just policy and governments. You have to look at what's the right balance between bottom-up and top-down. A government can say you have to use it everywhere. That has happened in some countries. You have to use it for financing, for example. Failure everywhere, because it becomes a financing instrument and you fill it out in a way that you get the most financing, and of course government notices that. You don't use it for quality of care, you don't use it for care planning, just for financing. So you play it, government notices and drops it and starts with something new. But you need support from governments as well, because if it's only bottom-up with the most motivated, you will have a group of organizations who will do it, but there will be a limit to that number. And it will, well, Finland has started bottom-up, and they have a vast group of organizations that continuously use the instruments, but there's also a vast group of organizations that never will use them if government doesn't force them. So you have to find some kind of equilibrium between those. You have to involve the community in general, and it will be paid at least partly by your tax money and by social security maybe. So you have to make sure that people know what it is, why it's used, and how it could benefit them. And you have to take account of social and environmental context and of the history of care and of organizations. You cannot start with a blank slate and do everything anew. There's always influence of how people worked before, what happened then, and how innovations were perceived before, etc. So there's a lot to take into account. And then you have to look at what exactly do we want to achieve. And you have to make that very clear to the users. And how do we want to achieve that? How are we going to help you to achieve that? And you do that also in collaboration with them. How are you going to organize training? What software will be available to you? What should that software look like? What would help you to organize? If somebody needs an assessment, how will you organize that? What would help you to organize that? And you will see that not everybody wants to achieve the same things, and they don't always want to achieve it in the same way. So you need some flexibility and some leeway there. And also, there's a lot of evidence from other countries, but what works in New Zealand, for example, doesn't necessarily completely work in the same way in Belgium. There are different contexts that you have to take account of. So what you do is, you have an intervention. Your intervention is to implement BelRAI with some key components, such as the translation, the software, the training, the manuals, the privacy policy. You also have a participatory implementation process with key components such as stakeholder engagement, interdisciplinary, I'll come back to that, interdisciplinary research is very important, and inter-university research, because if you want to cover the whole of Belgium, it will not be just with a Flemish university, you will have to have a partner in the French-speaking part of the country, for example. And you will have to have focus groups with users, usability tests of software, etc. And you'll have to have some measures that show you whether you make progress or not. So you need practical progress measures, the take-up, how many organizations, for how many people, the number of people trained, their evaluations of training, the usability of software, etc. So that's one phase. And even that is not the complete phase, there's more things to think about. Then there's feasibility and piloting. What do you have to think about there? Well, you'll have to be trying it out in different contexts. That's what we did for the first 4 or 5 years. We tried it out in nursing homes, we tried it out in home care, tried it out in hospitals, we tried it out in mental health, etc. And you collect quantitative data, assessment data. You see, well, we have a couple of papers on what types of items were often left blank, were not filled out, and why. And then we talked to them to ask why they didn't fill it out. So you also have to use multiple methods. It's not just quantitative data and some statistical analysis, it's also listening, focus groups, case studies, expert groups, etc. So quantitative and qualitative data. And the qualitative data will help you understand the quantitative data. And you also have to determine what sample sizes are necessary to be able to draw conclusions. For example, from the first year or the first project, government already wanted to know how much it would cost and how much money they would gain. But if you only use it in a couple of organizations, the most motivated ones to begin with, it's very hard to draw conclusions on that. You need larger sample sizes, and we're in that process now for nursing homes, for example. We'll need at least 3,500 assessments in a representative sample of nursing homes with a representative sample of inhabitants of those nursing homes to be able to draw some conclusions. It's also very hard to predict how much money you will gain. It's things that didn't happen. How will you know exactly how many hospitalizations were avoided? How do you know that? So piloting works a lot better also if there's a clear idea of when the piloting phase will stop and implementation will really start. And that too has been unclear for a number of years in the case of BelRAI. Among others, because there was a sixth state reform, and we started at the federal government and in elderly care. But after the sixth state reform, it was no longer the federal government responsible for that part of care. It was the different communities, and all of a sudden, it was Flanders and the Walloons and Brussels and the German-speaking community. So it took some time for them to come together and make a joint decision that they would all implement it. But since then, we also see that the pace with which they implement it is different. And yeah, if you start with the most interested, by definition, your sample size is not huge. Third phase is evaluation. Is it effective? Is it working? Do we achieve what we intended? And if we don't achieve what we intended, why don't we achieve it? Because the instrument isn't good enough? Or because the circumstances were not what they were? Or because something else was happening that intervened with what we wanted to do? And sometimes we find that in one organization it works perfectly well, in another that is very alike, it does not. Why? Sometimes it's because the most motivated manager left the organization, no longer there, and there was nobody to take up after him or her, and that took a while. Is it cost effective? You'll have to look at it at some point in time. And also here, interdisciplinarity is key. You need economists, you need sociologists, you need nurses that understand how other nurses work. You need psychologists that understand how people's minds work. So you need to have a very global view on what is happening in that world. And then there's the phase of implementation, actual implementation. You have to decide when to go to top-down then instead of only bottom-up. You'll necessarily need support from government, but you also need to keep the people in the field who were the first users, you need to keep them motivated. If government changes rules, then maybe they become demotivated. So you need to keep them on board, and you have to make sure that everybody trusts the system, that it will be fair and that the privacy will be okay. It also needs some finances. You cannot harvest before you invest. You have to sow first, and then you'll be able to harvest. There's no company, I think, that ever develops a new product by not first investing and then making profits. In care, I feel like, in innovations in health and care, I sometimes feel like we want to harvest before we have without even sowing something. We want to combine innovations with investing less. And that, of course, doesn't work. So you hear organizations asking for supplementary means for implementing BelRAI. And they'll need software, and they need hardware, and they'll need time for their staff to learn how to work with it. But they will also gain time later when they don't have to search for information that somebody else already had. And so you have to find some kind of story about that is convincing and that sounds fair to everybody. And it should also be, the use of those instruments should not be something on top of. It should be part of daily work. That's when it really will work. So it's an ongoing process that never stops. Mainly in Flanders and in the German-speaking community. The German-speaking community has the advantage that it's small and there's a limited number of organizations and people know each other. So there are already, we talk a lot about integrated care. Using BelRAI is part of being able to do more integrated care. Well, in the German-speaking community, there is already a lot of integrated care and the process of implementation is going quite smoothly over there. In Brussels, it's very, very complicated. There's people with different languages, there's Flemish organizations, but also French-speaking organizations. There's a mix, there's a lot of people who speak other languages. Very difficult there, it doesn't really happen. In the French-speaking part of the country, it is happening, but slower than in Flanders, which may have to have something to do with means, and there's also some cultural differences, I think. But in Flanders at the moment it's going quite fast, among others because the current Minister of Public Health has connected BelRAI with the Flemish social security system that is being developed and implemented. And it will be used for determining what type of budget you get in the future. So, because you first have to use it for quality of care and care planning, there's a whole implementation process going on right now. But it's not because it's going on that you never have to go back. There's different loops. For example, when interRAI will mandate a new version of the instruments, because nothing is static, people change, people's needs change, people's wishes change, so the instruments are being evaluated too. Then that may be a time when you have to go through the whole loop again, because all the software has to be adapted, everybody has to be retrained. If there would be, and there already is, there are also transformations in the way we organize care. That will have an impact on how they use BelRAI and how they can use BelRAI, we will have to go through the loop again, and it will be over and over again. It's not a process that ends. But it's very interesting to study, and MRC and the different phases help you to look at that. And so we published about that too. This is one example of how we used MRC to study how we could implement the palliative care instrument in nursing homes. And we'll talk a lot more about all of these things in 2020, when in February we'll organize the second World interRAI conference here in Leuven, where we hope to bring together 800 people from all over the world that will talk about their implementation and their research about interRAI, and we hope to be able to show a lot of beautiful things of what has been happening here in Flanders. And for now, the floor is yours for questions. Yes. Could you use a microphone, please?
What about confidentiality issues? Isn't there more of a risk when your information is online on a software program?
Yeah. That's a question that has been on our minds from the beginning on. There is a whole file, everything went through the Privacy Commission, and everything is GDPR approved. There is encryption, etc. I'm not that technically schooled to be able to explain it all to you, but there has been a lot of attention, and it should be one of the most secured things that there is. But it is, I think, everything can be hacked in the end, so that is a worry that exists everywhere. And exists more in the sector of mental health care than it does in physical health care, because also sharing information. You may want to share that you have difficulty walking, but you may not feel like sharing with everybody that takes care of you that you had a depression 5 years ago or that you had a psychosis 10 years ago. And government is aware of that, but right now you give your permission for sharing information with one yes. You probably did that at your local GP, that the information can be shared. And we're looking at possibilities, but that requires a change in law, and so we need government. To be able, that there would be different levels, that you could give permission to share your physical data and social data perhaps, permission to share your mental health data, and permission to share your, not interRAI, but your genetic data, which is even more privacy sensitive, I think. But yes, that is something that has to be taken into account at all times, and that will require innovation as we go, because things change. Yeah.
So you mentioned that filling out these forms takes a considerable time and therefore money and effort.
Yeah.
And that's a big hurdle. Now, in a world where we have increasingly automated collection of data and big data, is it not conceivable that some relevant data will be automatically collected in the background? And okay, they may not be exactly the same as what you're asking, but if they're sufficiently close or more or less equivalent, you could maybe learn a lot without people having to invest this effort, at least in some cases.
Yes, you're right. Not for everything. Your mood will, I don't think, quickly be noted automatically, but for example, how much one of the items is how much time it takes you to walk 4 meters. And people hate assessing that, because you have to put somebody up and you have to chronometer how much time it takes them. That is something you could very well do with wearables, sensors, etc. And actually, I'm working with other people here at this university on a project proposal to see whether we can do that. For a number of things, also for how easily you can go on your own to the bathroom. Not only because you will have continuous data then, and of higher quality probably, but also because certainly in home care it's often difficult for assessors to know. I mean, not everybody goes with them to the bathroom. You don't know how they manage and whether it costs them a lot of effort to do that. And the second reason why that would be a good idea is that right now, for all ADL, activities of daily living, and instrumental activities of daily living, we look at whether they are performing them. For IADL, we look at whether they are performing them and whether they could perform them, because you may not cook because your partner always cooks, but you're able to, or you're not able to do it when necessary. But we don't measure how much effort it takes you to do it and whether you have to make trade-offs. So for example, you can cook your meal, but you're so exhausted afterwards that you cannot go to a social activity in the afternoon because you have to take a nap. That should also be taken into account because it has an impact on your life and on your quality of life, and it should have an impact on your care plan. And wearables and sensors could help us do that, perhaps, to take more account of if you have also heart rate and things like that, to take account of fatigue and trade-offs people have to make. So yes, there's another loop in there for doing that. On the other hand, if you say it takes a lot of time, it does. And if we give training, people complain at the start, and because so much, do we have to do all of this? And then we usually ask them to let us know at the end of the training process what items we can drop. We have the same thing with the rehab instrument we're developing. I think right now it's far too long, but we can't get anybody to drop something. They all say, well, it's too long, but I would like to add this and that. So it's a minimum data set, and interRAI really tries to make it as minimum as possible. But because there are a lot of topics, you need a minimum number of items on every topic. The solution is on sharing the burden of assessment by having different people fill it out. And also, I think if you think about it, if you're an experienced assessor, it will usually take you about an hour for a first assessment and less for follow-up assessments. An hour is a long time, but on the other hand, if you can't spend an hour on determining what's going on with that person, how are you going to draw up a decent care plan if you don't know what's going on? It's time well spent, I think, but it is time spent. And we know that there's a lot of burden of work for people in care, and that's something government will have to take account of. Yeah. Any other questions? There's no questions online? No. Okay.
Thank you. You started your presentation with mentioning that the data follows the person, ideally from birth throughout the lifespan.
Well, if you're unlucky that you need it from birth on.
Okay,
yeah.
but I was wondering, are there any rules for timing or timing of a reassessment or reevaluation? Because I can imagine, especially the ADLs, that they change throughout your lifespan. And I was wondering, are there any rules for when you have to reassess someone? And that's my first question. And the second one, if you have to re-evaluate someone, what happens with the data flow then? Is the old format just deleted, or is there some kind of evolution in your data?
That depends on the software, of course, but I'll start with the first one. There are guidelines on how often you re-evaluate somebody, preferably every 3 months. Every 6 months is also a guideline, and it will depend on your professional judgment as well, because some people are very stable and other people, situations change a lot. So it is also a decision of the care team. But it will be at least once a year, preferably every 3 months, to have a look at it. That is made a little easier by what is the answer to your second question. The software we use in Belgium, we have BelRAI 2.0, is a software system which is available by government online, but is also a package that you can build into your own software in your organization. You sign an agreement with government, you get the whole package, you can build it into your own software, or you can build commercial software that you can sell to others, and there's one company that already does that. It means that you can, when you have a second assessment, you will at least see below what the previous assessment was, and you can then decide to copy it. Or some software will show it, and then you have to click, yes, it's the same. There are a lot of benefits to that in time and in terms of time and effort, and not frustrating people with having to answer the same things. There are some setbacks as well. You have to, at least once a year, you really have to look at if nothing happens, because maybe you automatically start clicking it's the same when it isn't. And so when at the first projects, we were really scientifically sound, so we didn't show anything from a previous assessment, and you could, at the end, you could see evolutions. Yes, but not while you were filling it out. But we had to come a little, that's one of the parts in the process. When you talked with users, they found that horrible. They didn't want that. They found that far too time-consuming. It had already been done. Nothing had changed in these areas and only in these areas, and they didn't want that. So Now we spend a lot of time during training making them aware of the fact that they should never do this automatically without thinking. And there are also, training is followed by intervisions in which they exchange experiences, and also an assessment is done jointly to see whether everybody does it right and in the right way. There's been thinking about also having some e-learning to test whether you're still on board, etc. So it's finding an equilibrium between the quality of the data and the feasibility of the assessment. Yeah, over there.
I wonder about super diversity and stuff, about what you do with people that don't speak the language yet or stuff.
Well, BelRAI does not solve everything. It doesn't solve that. It will indicate that somebody is talking another language, but it's other parts of care that will have to train people, or will have to. There is a number you can always call for translation in care. I'm forgetting the right number right now, but there is some kind of interpreter in care, so you can, when you're at somebody's home and you really don't understand each other, you can call that number and there will be somebody who helps you to translate. Super diversity is covered by interRAI in the sense that the instruments, if the new instrument is tested, it's developed. It's usually developed within one country in a research project, like we do with the rehab instrument now. And then it's brought to interRAI, which has an instrument and scales development committee that meets a couple of times a year for 4 days someplace and work together for long hours. And then they usually ask other countries to test it as well. And when there are, if other countries from all over the world start testing it, you see whether there are intercultural differences. I think the most important right up till now was in the palliative care instrument, where you have countries that have legislation around euthanasia and countries where that is something you really don't talk about. And so some of the items are country-specific. It's indicated in the list, and you can change it accordingly, or you can have good motivation not to ask them or ask them in another way. But that is also documented. So when you do international studies, you can see where the differences are. But it does work in Singapore and in Belgium, so you should be able to assess anybody from any other culture in Belgium with them.
Are there in Flanders other existing instruments?
How many?
Are there more other
instruments
who work in the same way of?
The choice for interRAI was made here in Belgium after a study done by the Interface group, led by Jan de Leperer from this university, and there was 6. So Frank van den Broeke was still Minister of Health at the time, and he asked for an instrument that there were 6 things that it had to do, and it had to be. You had to be able to use it across sectors. It had to be internationally validated. It had to force you make you collaborate. It had to help you make a care plan, and there were some other conditions. And interRAI, in that study, they showed that interRAI was the only one doing that right now. There are other instruments that are just as well in one sector, but not across sectors. And yeah, it's as an instrument, it's probably not better than others separately in home care or in nursing homes. But the big advantage is you can use it as a suite across sectors, and you can compare. And there are other countries using it, so you can also compare data. No more questions? You can also find the references, and I'd like to invite you to the next seminars in May, October, and November, where some of my colleagues will explain about other Lucas research on implementation. And with that, I'll thank you for your attention. Thank you very much. Dank u wel.